1997 from Melbourne University, and trained in comprehensive epilepsy care at Sri Chitra, Trivandrum. Awarded clinical epilepsy. Yes. Sorry for the...
That's all right. That's enough.
Yeah.
Name is enough. Thank you so much, Dr. Snigdha.
Sorry, sir. There was some problem with the screen sharing.
Not an issue. Not an issue at all. We'll carry on. So you can stop sharing your screen, and I'll add mine. So I would like to thank. You want me to start, or?
Yes, sir. I'm just stopping my screen.
All right. Yeah. So
I would. Yes, sir.
Sorry, you were saying
something? Sir. Yes, sir. You can share your screen now, sir.
All right. Thank you, and thank you, Dr. Vishnu and Anu, the organizers, and also Dr. Padma and Dr. Lal and the HODs for this, and everybody who's involved in this actively. It's wonderful to have this online and not miss this year. So I'm happy to be involved in this. I'll share my... Okay. All right. Hope you're able to see the slide properly.
Yes, sir.
All right.
Yes, sir, we are able to see.
Okay, thank you. So the topic is pragmatic indications of new anti-epileptic drugs today. And although there is a debate which are the new and newer and newest, usually this line here is the one which is drawn. So the drugs before that, the 4 major drugs and couple of others are taken as older, and the rest with this steep curve in the last about 3 decades are known as relatively newer drugs. So this is the arbitrary line drawn among the drugs. So what I plan to discuss today is I don't plan to go into details because, a lot of things can be read. I'm going to show you some stats, but not everything in detail. That gets very boring, and you've probably heard other people and me also in many meetings talking about these things. So we'll go for the need for the newer anti-epileptic drugs and their value in drug-resistant epilepsy. Then we'll go into side effects, interactions, and comparison of efficacy with the older drugs. And then I'll just talk briefly about the latest drugs in the Indian market. And then I think we'll all be able to come to the pragmatic indications. I won't be putting up cases because the cases very relevant to this presentation are going to be discussed after the presentations. So so these are the drugs. So you can see these new anti-epileptic drugs from levetiracetam, clobazam, lamotrigine, oxcarbazepine, right up to brivaracetam. They're called the neuro anti-epileptic. They're all wonderful drugs, and I use all of them, almost all of them, very frequently. And they all look nice and very, talented in their own field. But the issue sometimes comes is that due to a lot of pressure and marketing, we tend to ignore the old hands, which are doing quite well actually, and they are still in the reckoning and giving stiff competition to the new drugs. But it's not a perfect analogy what I'm showing among these actors and this thing is because the difference in marketing. So you can see that all the media attention is still on the older actors who are doing well, whereas the marketing attention in anti-epileptic drug has totally shifted apart from maybe valproate. Nobody else usually comes and promotes them, and there is a lot of promotion of these drugs. So and in this case, the public doesn't have any say. So that is why it is most important for us to act as advocates, patients' advocates, and give them the right perspective about these medications so that they can make an informed choice. So what we expected when we were looking for new drugs, why we wanted new drugs to have lesser side effects, fewer interactions. I think someone's mic is on. Can you please mute other people? Yeah. Um, so and easy to combine, and safety in pregnancy was quite important, and seizure freedom, of course, is the main thing. So what all have we achieved? What all we could achieve? That's good that we could achieve at least these three things here, the few interactions, and they are easier to combine, the newer drugs, and much safer in pregnancy compared to at least few of the older drugs which were quite unsafe. But regarding the lesser adverse effect, I'll come to that. The seizure freedom is still a problem. When you see these studies come, they're all in DRE, you see 50% seizure reduction in 50% of patients. That is usually the criteria being used. So that becomes quite frustrating that it's very low seizure freedom rates. It's seizure reduction. Even in the latest drugs from levetiracetam to brivaracetam, the seizure freedom rates are quite low. So this is something which we haven't been able to crack yet. So, this is a cliche line which is used when someone needs to break up. They say, it's not you, it's me. So in this case, this girl is the DRE, and this boy is the current anti-epileptic drugs. And she's right, actually, the problem lies with the drug-resistant epilepsy. We haven't cracked one door of it. Actually, we don't know that door. So we are all attacking one door, and we are able to open it. Almost all the drugs are able to open it. But the problem is, this problem is not about the drug. It's about epilepsy. This is a study which you can see is a very famous quoted study of Brody and Kwan, which shows the seizure freedom rates after 1, 2, and 3 drugs. And you can see with one drug 47, with the second drug 13 and 4, and then 36% still resistant after drugs. The same authors published a couple of years back, last year, in fact, another study after so many decades, and you can see how less is the thing changed. It's ultimately it's from 36%, the DRE level is down to about 33.5%. So that's not very encouraging. Although it's not that they are not useful, I must say here that their new combinations may still have. And we just had a discussion in one of the meetings recently that we must keep trying, especially the newer mechanism of actions. And many of these, it may not be a uniform phenomena. The percentages may not be that better. But in some patients, selected patients, they may actually help. So the idea is that we should keep trying with new combinations up to a limit. And what is the limit? We still don't know. I mean, so how many should we be trying? All anti-epileptics? I guess a reasonable thing would be to the best 3 or 4 drugs in that line should be tried, and we don't stop at 3 drugs as a strict rule in drug-resistant epilepsy. So coming to the adverse effects of the newer anti-epileptic drugs. So whereas sedation and somnolence is concerned, there's not really a big difference between them, apart from lamotrigine, which is supposed to have a better profile on cognitive. So that is something which is different. As far as dizziness and ataxia, overall lamotrigine and levetiracetam are better than carbamazepine. And that is where it scores over this drug in retention of the patients. But the comparative drugs in the same group, eslicarbazepine and oxcarbazepine, are really not significantly different than carbamazepine and much more costlier. As far as serious adverse events are concerned, bone marrow suppression or polysystemic syndromes, of course, they are more common, not very common again, they're quite rare, but they are present in older anti-epileptic drugs. Whereas in newer anti-epileptic drugs, we have seen very few really serious syndromes till date, because we are still discovering, as I will show you in one of the slides. So we need to know about these and not go by what is being told to us that these are like all great and good. Let's come to some individual side effects of these drugs. I'm going to just skim over these slides. It's actually just to tell you that like drugs like Parampreet at higher dose can have almost 50% rate of dizziness. Lacosamide at high dose can have 30% dizziness, and diplopia also, since it's a sodium channel drug. Carbazepine, again similar, all of them have side effects, so we should not just go by that they are devoid of side effects. Even brivaracetam has somnolence and even psychiatric comorbidity, although it is being promoted as a drug alternative to levetiracetam without psychiatric comorbidity, but that may not entirely be the case, although my personal experience is very limited, but it also can have psychiatric comorbidities. Now coming to interactions of new ADs. So this is where they really score. They are much better than older anti-epileptic drugs because they are not inducers or not get induced. And so they do not interfere with the metabolism of other drugs. And some of them may not get affected too. I'll just show in the next slide. So this is how we see them. So these are enzyme-inducing drugs. These are non or weak inducing. These are amenable to induction. That means they're hepatic metabolized. And these are not or very insignificantly amenable to induction. So you can see most of the newer drugs, along with valproate, come into this category. They do not decrease the levels or interfere with levels of the other drugs. Whereas 3 of the 4 older drugs have both induction and get induced, so that is a disadvantage there. Whereas levetiracetam and a couple of these other, this is the most actively used one, is a drug which neither gets induced nor induces. So this basically what we call is a doubly inert drug. So that is why you will see out of all the new drugs, this is the one being used right, left, and center without knowing much about the patient. But you must remember that brivaracetam does not fall into this category because it does get induced by hepatic enzyme inducer. So that is where levetiracetam even scores over brivaracetam. So ideal combinations would be 3 with 3, 2, or 1. All would be okay. Suboptimal will be obviously 1 with 1. They both will be decreasing their each other's levels. And slightly better would be group 2 with 1, whereas this would decrease levels of group 2, but group 2 will not interfere. So that is the second choice apart from using group 3. Now coming to efficacy, this is a Cochrane review in 2017. They have done extensive comparison, some direct and some indirect, in the anti-epileptic drug efficacy and tolerability. So what do we see here? This is in partial seizures. These are 12-month remission time. So this is basically efficacy. So this is carbamazepine group. This side, if there is, the carbamazepine is better than the drug. If this side, carbamazepine is worse. So you can say carbamazepine is not worse than any of these drugs. Oxcarbazepine comes near to it, but levetiracetam, lamotrigine, carbamazepine scores much better in that. And oxcarbazepine is almost equal. Coming to time to first seizure, again another indicator for efficacy. You see levetiracetam and lamotrigine still are below carbamazepine here, and even oxcarbazepine is less effective, which is our experience too. We should not talk about anecdotal experience, but over these decades of practicing epilepsy, sometimes these patients do not respond. My refractory patients to oxcarbazepine, sometimes when we change them to carbamazepine, they do well. And so area where levetiracetam and lamotrigine scored better than oxcarbazepine was the time to withdrawal of allocated treatment. That means tolerability. It was a little more subjective reason, but yes, there was an advantage there compared to carbamazepine in partial seizures, where oxcarbazepine still did not score over carbamazepine. This I've combined for the generalized seizures. This is the same thing for generalized seizure. Mind you, these are all GTCS with or without. They did not differentiate myoclonus absence. So these are mixed. Some of them may be secondary generalized. These are not primary generalized epilepsies, haven't been differentiated in this. But what you can see is this is valproate better and valproate worse. So most of these indicators, whether it is allocated treatment, retention, or these efficacy parameters, everywhere valproate scores over most of the drugs. Couple of areas here, phenytoin has scored better. Maybe these were secondary generalized seizures. It really they've not explained how it has come to show that. But most of the other drugs like levetiracetam and lamotrigine and topiramate, efficacy-wise, they were not exactly same than valproate. And even tolerance-wise, some of them were not as good as valproate. So the interpretation, what I would draw is that in partial seizures, efficacy-wise, carbamazepine is almost equal to oxcarbazepine, which is better than lamotrigine and levetiracetam. Retention-wise, lamotrigine was better than levetiracetam, which was better than carbamazepine and still better than oxcarbazepine. So carbamazepine is equal in efficacy and better in retention, so slightly scores over oxcarbazepine in these matters. Whereas in generalized seizures, if we just talk about valproate here, was better than the other two competitor drugs, whereas retention-wise, lamotrigine was slightly better and valproate was better than the other drugs again. Coming to pregnancy, of course, levetiracetam and lamotrigine, as per current data in the registries, they are better or lesser major congenital malformations, quite minimal compared to many drugs, and especially topiramate and almost extremely in the case of valproate. But the cautions is that topiramate, we are seeing more and more cleft lip and palate now, which we didn't know before. So that is why I'm saying the adverse effects are still coming of these newer drugs. And the recent thing is falling drug levels in mid and late pregnancy, which can be very significant. We knew about lamotrigine, but now we know that levetiracetam levels also fall up to 30 to 50% sometimes, and they start in end of first trimester or second trimester. So these things have to be, so these are the favorite drugs for pregnancy. We have to be very careful. So the significance, there is not very good literature available yet, but there's a lot of literature coming which tells us that recommended are the level monitoring. And if we can't do that, maybe dose increase in the second and third trimester. I would like to get the views of other panelists, other people on this, what you are practicing. So just as I said, I'll just be talking about the value of the most recent newer anti-epileptic drug before I go to the pragmatic indications. So perampanel again came as a alternate. It's a little expensive drug for refractory epilepsy. We also have used significant numbers in our drug-resistant epilepsy. It did help, but mostly at the higher doses, which many patients did have side effects. But although it is part of armamentarium, it was a good addition. But again, it did not score too much over the drugs which we already have. So that is why the enthusiasm over time is slightly decreased, but we are still using. Brivaracetam, since the literature was not extremely powerful, my personal experience or our center, our team, our epilepsy clinic, all of us do not have too much of experience. Although there are reports coming from me, or Jitu, Kamlesh, whoever uses these drugs, that some of the patients do get lesser psychiatric side effects, but I would not want to talk too much about it since some patients also did have worsening. So I'll wait on this drug for more experience. In the near future, cannabidiol we don't have, so we don't need to go into it. There's a lot of excitement, I think, predominantly because of the marijuana, medical marijuana thing. But the excitement waned, something like, as it did not have THC in it, so the cannabidiol or CBD does not give a high. So, but it's still a good alternative. Not like it, I think it was overly discussed because of the cannabis where it's coming from. But in Lennox-Gastaut and Dravet, it has been used, and trials are going for other drugs also. Although there's a doubt about the Freezy or a clobazam association where does it enable clobazam effect better, and that is why the effect is more clear. We'll come to know about it in coming. There are other drugs in the future pipelines. I think only once they go through their phase 3 trials and all, we'll talk. But anakinra is one which is being talked about because it has it's a IL-1 inhibitor, so anti-inflammatory or maybe anti-epileptogenic effect may be there. So this is something we are looking for because most of the drugs are not anti-epileptogenic. If it becomes successful, it may give us a chance at those uncracked drug-resistant epilepsy cases. So the overall comparison, efficacy-wise, we see that the old drugs are slightly better than new or slightly better to equal. Adverse event-wise, new drugs are slightly better than the old ones. The interactions-wise, of course, new drugs are better, and affordability-wise, old drugs are better. So there is almost like a tie between these things, but obviously we need to find out where exactly we should be using which drug. That is my purpose today. So I'll come to my pragmatic indications. Why I say my pragmatic is that because people have debated on it in many forums and debates in conferences. People have their own choices, but I'll tell you based on all the experience what I would find them. So all these drugs, can be used as add-on drugs in drug-resistant epilepsy, and we do use them. Most of them in partial zonisamide in the generalized epilepsies too, and in polytherapy, AD polytherapy, because of the reasons I said, they will be good drugs to be in combination because of the inertness, relative inertness, and replacement of older drugs if not tolerated. My indications for first line use would be. My indications for first line use would be women with epilepsy, especially this stands for women with childbearing potential, because that is where it really matters. In IgE, in myclonus, levetiracetam would be first choice. In absence, maybe lamotrigine. In focal epilepsy, we're not sure. We need to weigh, because in focal epilepsy, it's carbamazepine or oxcarbazepine versus levetiracetam or lamotrigine. So the valproate disadvantage, severe MCMs may not be there in carbamazepine. So we'll have to see if they're well controlled, maybe again levetiracetam, lamotrigine. But if there is a difficult case, you still might end up giving carbamazepine so that the seizures don't come back, especially low dose. In elderly, especially hyponatremia, levetiracetam, lamotrigine, maybe valproate would be my choices. Preferably not oxcarbazepine and carbamazepine because hyponatremia is a side effect. In comorbidities and their treatments, inert drug like levetiracetam is a good drug, and lamotrigine, and also valproate. I'm just focusing on the indications for newer drugs. In broad spectrum requirement where valproate is not feasible, again levetiracetam. Topiramate is a good drug. It scored over in Senate trials, lamotrigine in generalized epilepsies, but we know it is limited by high dose with psychiatric side effects and the other side effects, word finding difficulties. In liver compromise, levetiracetam is a wonderful drug because of its not being metabolized in the liver. Other drugs which are not that much used in epilepsy, but possibility is gabapentin and pregabalin. Cognitive issues, as I said, most of the drugs cause cognitive impairment, but lamotrigine possibly causes least of it, so that would be a good choice in these patients where cognitive issues are there. In psychiatric issues, especially diagnosable psychiatric disorders, there's a lot of literature, and we have also done a study that preferable to avoid levetiracetam, and also maybe perampanel and topiramate, and use valproate if possible. In weight gain, topiramate causes weight loss, so that may be a possibility. Skin rash, clobazam doesn't cause skin rash, so that is be a choice. When carbamazepine has interactions or other issues, oxcarbazepine is a good efficacious in partial seizures. Where levetiracetam is not tolerated, maybe brivaracetam, but I've just put a query because of lack of my personal conviction and and personal experience, I should say, not more than conviction. And if you're in a hurry, you don't know the type of epilepsy, you don't know much about the patient, the comorbidities, I think levetiracetam is something that is what is happening in our emergency too. You can start and then can be modified later as per needs. So ideal is, the debate should end. It should be a happy marriage between the old and new. And there is emerging evidence that we can, if we choose properly, the generational divide is decreasing and should decrease. So I'll end here. So all we need is that something which goes and pierces this DRE, which we still are waiting for. Till that time, we need to do the best we can. And I mean, for the residents and trainees, if you are ever stuck, I mean, I always tell my residents here is that give or use a drug which you would use for your own child, although I wish nobody has these problems, but it's just a metaphorical thing that once you want to use something for your family, that should be the one you should be wanting to use for the patients also. Thank you.